Get ready as we scrub in and dive deep into the question of what is your why? We'll explore personal stories, practical lessons, insights into innovation, health education, and more.
Join us as we talk with doctors, healthcare professionals, and community members to learn why they chose healing, hope, and humanity.
All right, everybody, welcome back to Scrub In, episode 4. And today we have Dr. Lydell Lettsome, who is the director of the Bayhealth Wound Care Center.
Welcome.
Welcome.
Thank you. Great to be here.
Very happy to have you today. So we always start every episode off with reading a quote. So today our quote is, "As soon as healing takes place, go out and heal somebody else." And that's spoken by Maya Angelou.
Yeah. So tell us about yourself. Welcome. We're excited to have you. We want to hear about you.
Well, where to begin? I am native-born Brooklynite, and so like that 20% of Americans that have some connection to Brooklyn, I'm one of them. But I also grew up in Philadelphia as well, so about half of my childhood is spent between two cities, and really dive into both cultures, although I think of myself way more being from Brooklyn than Philly. I'm Caribbean American. I'm the first generation Yankee in my family, so those things of being an immigrant is still really salient to me as I've watched how immigrants are sometimes thought about, and particularly in today's culture. And for most part, I tend to think of myself as one of those people, like, well, how do you, when you say you view yourself, I think and hope I'm one of those natural American citizens, like the neighborhood, the boy next door.
Okay.
Did the regular things. I grew up poor, but still did a lot of the regular things: scouts, sports, the camping things. Sometimes I think when people look at me, and my nurses were teasing me yesterday, it's like, oh my gosh, you're one of those survivalists who will just go out. I was like, well, if apocalypse happens, you only got about 10 days, and you've probably outlived half the population. Just go hole up somewhere. You'll be fine.
Yeah. Now, do you have the food and the water and everything saved at your house?
Oh, yes.
Maybe beyond that?
We've prepared.
I have a bug out bag. Yes,
Nice.
I do. It's like I said, it's sad to think of society that way, but really, if you could just grab 2 Foot Lockers, go and hide in the woods somewhere, dig a 5-foot deep ditch. When you come back 10 days later, half the people will be gone.
Great thought. Well, and you're in wound care, so you'll at least be able to keep that going for yourself.
We'll have a leg up on that one there.
It was just random craziness, but it just, we talk about this the day after Halloween and going through all of these apocalyptic movies.
Oh, gosh. Yes.
Shouldn't happen, but if it does.
Yep.
You're ready to go.
Good spooky start to this episode, post-Halloween. So what brought you to Delaware from Brooklyn?
A combination of things. Like I said, I spent half my childhood in Philadelphia, so my mom and my sister are still in the Philadelphia area. And when the recruiter called me, I said, oh, well, I used to come down to Delaware and Rehoboth and hang out with college people. And I was like, all right, well, sure, let's see what this opportunity may be like. And I got down here and was really impressed with what they were saying to me in terms of the opportunities of what I could build here. Very excited about the fact that there's a real need here. It just fits into why I went into medicine. And the opportunity to where we were before, we were sort of on the edge of the family travel spectrum. Now we're in the heart of it. So for my kids to see their cousins and relatives more often is definitely a plus.
Yeah.
That's awesome. Yeah, that's certainly why we moved to where we are, so that, our kids could be with their cousins, with their grandparents. So, absolutely. Now, what took you into wound care?
That's wow. Some might say laziness, but no. Wonderful opportunity. It was really random. The first exposure to wound care as a specialty calling. I was the director of our ambulatory clinic in Brooklyn, and they had an issue in one of our nursing homes where they were having some wound breakdown things, and the person who was responsible for it was incapacitated. So I get a call from the CEO of the hospital saying, hey, we got a real issue. We might lose a client, blah, blah. Do you have any exposure in this and whatever? And of course, you're never going to tell the CEO no. So yes, even if you go home and read the book later. But I said, yeah, I'll figure it out. And I went and met with the nursing home directors. And it was a great experience learning from the population management problem, what they were worried about, how bad this can go, how they have to inform families. And we were thankfully we were able to quickly work out a strategy and a plan. But that was the first time I really saw, hey, you got to have like an intentional methodology on how you handle people with wounds.
Yeah.
And then the second exposure was I was doing my general surgery, bariatric surgery, and one of the partners came to me and said the hospital needs someone to cover their wound clinics, and it's at the hospital you're at. We were covering 3 hospitals. Do you think you can do it until they find someone? I said, sure. It just, whatever. And when I got there, it really, once again, reminded me of the need. And the nuance to that second exposure was the multimodality aspect of it. We tend to think of multimodality really only in cancer, but it's in wound care. When you are seeing a wound care patient, you need to be thinking about infectious disease, you need to be thinking about cardiology, you need to be thinking about weight loss management, you need to be thinking about all the social determinants of health, you need to be thinking about nutritional aspect. So it's a whole lot that you have to see and think about constantly just for the wound. When I lecture to residents, I tell them that for chronic wounds, which is the field of wound care, the wound is the symptom. It's not the disease. And if you're going to really make a impact on the wound in the patient, you want to figure out what symptom does this wound represent? Like, what is the disease process that's gone out of control in the patient's body that this wound can't heal?
Yeah.
Right.
I saw that with my dad last year. I moved him up here to Delaware. He had osteomyelitis and an awful wound, and he moved into our house, and we were doing twice a day intense dressing changes. And even though we were doing all the right things and we were putting on stuff that I had never even heard of, and I was following all the rules, the underlying cause was that osteomyelitis. And when that started worsening without us realizing it, the wound all of a sudden started to worsen. And so it was a matter of like a day that in the morning we changed the dressing, in the afternoon we changed it again, and it was a totally different wound. And and it ended up being related to, a worsening osteomyelitis. And so or an infection in the bone, for those who don't know what that is. But you're absolutely right. It is something to see how you can do everything on the outside perfectly to protect the wound, but you got to treat that underlying cause, and that is what a puzzle.
Yeah, it's detective work, which fits my personality and mind. So, from surgery where you're doing all these things, and the whole thing of the surgical aspect, like surgeons, we're aggressive. It's the euphemistic word for us, but our mindset is completion, and that's also on the table of wound care. You're expected to try and get the person to some end or some way where they could lead their life functionally. So it's not that much different in surgery in terms of the expectations. The huge difference, which has turned out as other things have happened in my life, is the lifestyle is different.
Right.
So you still got to be thinking, still got to be researching, and still really pushing and prodding other clinicians to keep up sometimes. But you just have a lot more opportunity to be home on the weekend, be available to your family and kids. My Lord, and just not forget just being the surgeon, but getting to be the surgeon, the amount of family events I missed, because I was always someplace else.
It's a commitment.
Yeah. I lived the on-call life for a number of years and slept with my phone and don't really remember my second child's first year. And so, yes, I agree that that if you can do what you love and still, have that surgeon's heart and be able to do something that gives you a little bit better lifestyle, sometimes that is the way to go. Absolutely.
Yes, it is.
So, yeah. Now, one of the things that we always ask everybody, and we've kind of touched on this, is, what is your why? What makes you get up in the morning and continue to be a wound care doc?
So I guess, so yeah, that's interesting. I break it apart in my mind in two different ways. The first why, in just terms of the physician, money, respect, altruism. And I know when I don't fluff it up and just put it as raw as that, people are like, did he just say money? And I was like, yeah, as I said earlier, I grew up poor and learned very quickly, for all of our Christian mythology and morality here in America, we were really mean to poor people and really dismissive and judgmental of poor people. And as I was just growing up and people started saying, as you start going through the school system, oh, you're kind of bright, got some potential. It's like, yeah, I need to find a way where I'm not living from paycheck to paycheck, even though a lot of us physicians still end up living from paycheck to paycheck, but we don't get financial literacy. And wanting to find an occupation where I had a legitimate opportunity of generational changing wealth. And I haven't really done it since I've been here in Delaware, but when I lived in New York, I used to do a lot of talks to young people. I'm a huge, huge sports nut and played sports in high school and college. But at the same point, the math doesn't math if you're just going to compare professional sports to medicine. You take the NFL, which is about 1,700 spots, the NBA, which is about 500 spots, Major League, which is about 600. I don't know what the WNBA is. The NHL is close to the NBA. All of those four major sports, the average career span is about 5 years.
Yeah.
The minimum wage is about $1 million. No, not the minimum wage. Minimum wage is actually like $500,000, which is still real money. But the average salary is about $1 million. So just the math: 1 times 5. 5 million, you're done. You got to live off the rest of that somehow, particularly if you didn't manage to develop any other skill sets.
Yes, yes.
Meanwhile, American schools, forget even the foreign ones, are accepting 40,000 people, graduating about 40,000 people every year. Just way more opportunity.
And we need you.
Yes.
We need professional sports people as well, because it brings us joy, but we really need you.
And it's a 30-year career. So, yeah, I mean, yes, the super specialists are making close to athlete money, but the regular people still at that $300,000 over 30 years. You've made pretty much the same, if not more, and it's almost guaranteed. It's like medicine is one of those weird professions. Even if you're injured, if you know what you're doing, you can generate revenue.
Yeah, absolutely.
Right.
And then just the respect aspect of it tied into the poverty. I didn't grasp it concretely until I was in residency, but I did see Quincy, the show that inspired me to really look at medicine as a career. Everywhere Jack Klugman went, he was sort of respected or given pass to ask his questions, do his job, push the needle, move the envelope. And as I lived out my life seeing that, and the few clinical people I had access to or exposure to, same thing. And I try to tell that to colleagues when they listen. It's this privilege and burden. If you are a physician, and it's sad not to disrespect other clinical people, but if you're a physician, you are automatically, whether you are worthy or not, a community leader.
Yep.
You might not be worthy of that, but you are. And neighborhoods and places are measured by, do they have a hospital? How many physicians? Like, it's right after their schools and
Right.
So what you can do to make the lives of people better just beyond the exam room. Medicine is one of those few professions that allow you that opportunity.
Absolutely.
And that's where the altruism ties in. It's just, at its core of its definition, it's a selfish concern for others, which is unfortunately really lacking in the American psyche right now. We love to talk about people's choices in America. We shun away from talking about the opportunities available to them, and that's just sad. Like, at the end of the day, people can only make choices based upon the opportunities they are aware of.
Yeah.
And so, being a clinician, the exposure that gives you, the ability to tell others, hey, there are different pathways to think about your life, whether it's financial literacy, housing, retirement planning. I love it when I say to people, like, you do know retirement is not an age thing. It's just not needing to go anywhere to pay your bills.
Yeah.
You
Yeah.
know, it's like it's not like this thing of somehow you got to wait to 65 and no longer work. Who told you that? There are plenty of people who don't work at 40.
Yeah.
Just talk to the average fireman and police professional who are happily retired at 52, right? You know, like, it just, like, figure out a way where you don't need to be dependent on somebody to pay your bills. It's those kinds of things, and when it comes from you as a physician, people tend to listen to it. And then, as you alluded to earlier, that we can really go in someplace, and even if we're there 20, 30 minutes, my God, actually make a significant, resounding difference in someone's life.
Absolutely.
And whether it's the dressing, washing their feet, combing their hair, like those aspects that sometimes gets forgotten in medicine. People come to us very broken and
Right.
very exposed, and we can really help them leave a little bit more hopeful than when they first met us.
Absolutely.
So that's the joy of it, and it sounds weird when you say money, respect, and altruism, but it all connects if you follow what the overall goal is.
Absolutely. No, I hear what you're saying, and what a great path that you've taken. Now, along the lines of your altruism, you also have a nonprofit. Is that right? Tell us about that.
It's called the Van Bird Health Equity Project. We are about 4 years old, and it evolved out of two things. And I should have probably brought you to a copy. In 2012, while I was running a breast clinic in Brooklyn, I saw that a lot of the immigrants and a lot of the green card patients and a lot of the Medicaid HMO patients, the access to what they had did not remotely match the access to
Yeah.
what people in Manhattan had.
Absolutely.
It's less than 4 miles away.
Yeah.
And as I started talking to people about it, and at this point I'm also getting promoted through the hospital, so having exposure to different levels of statistics and things and community health data, really saw that this healthcare access is a much bigger issue in America than we think. And it really changes your lifespan.
Yeah.
Brooklyn, the one that got a lot of press was St. Louis, Missouri, where it was barely 20 miles apart, 15 miles apart. Same city, 20-year lifespan difference in the
Wow.
same
That's
city.
that's insane.
Yeah.
So that 20 years is extreme, but in many major American cities, including Philadelphia, 12-year. Just think about that when you say the average lifespan is 75 years old. And one person, just based upon where they were born, is going to die at 60 as opposed to 75. Think of what that means in terms of what they get to share and do with their grandchildren. Think about what that means in terms of how much income they could generate. Think about what that means and what they could see and experience if they are expected to die a full 12 years earlier. And the 10 years prior to that, that 50 to 60 is not even living well.
Right.
They have CHF, out
Right.
of control diabetes,
All those comorbidities.
All
bad
the-
wounds, right?
Yeah. All those chronic issues. Yeah.
And it's literally based on the neighborhood they were born into. So as we start to really think about social determinants of health here in the Bayhealth and Delaware area, it's not theoretical. When I sit on the hospital's AHA steering committee, it's like, this isn't theory. This really impacts
Absolutely.
how people live and how long and well they will live. So that was what got me to realize, all right, what are the drivers of this? And one of the big drivers from the policy standpoint is we're the only industrialized country in the world that doesn't have universal health care.
Yep.
So I wrote a book about that and what it would mean and what the possibilities are of having universal health care and a capitalist economy, which we would also not be the first. Germany, Great Britain have successful universal health care models in their very much capitalist countries. And as that kept growing, getting me context to other things, realizing that I'm a Christian, and that realizing that the churches have a lot to say about things like abortion and smoking and drinking, but almost virtually silent on the policies that would make people choose those choices.
Interesting.
And so Vanbert got birthed out of that. Like, how do we educate pastors and clergy leaders on, hey, even if we agree or don't agree with what you just said, why don't we talk about some of the actual policies that exist in this country? Because lo and behold, if you're a pastor or a priest, you're also another community leader that politicians listen to.
Right.
So why don't we talk about the policies that are affecting the issues you're preaching about, and how you could use that to leverage to improve the life of your community. We literally call it physical salvation. Like, that Jesus didn't just come, die, and rise so people could be saved for heaven. He also came so that they could live a better life here. If they're coughing every day, that's not a great life. So,
Right.
Yeah. Something to think about.
and that's where the work is. A lot of behind the scenes work. We're now evolving into, all right, if we want to raise more money, we got to have a public brand. So as we go into year 4 or 5, we're now, our strategic plan is, how do we kind of let people know what we're doing? Because we never really thought about having subscribers and followers. We spent a lot more time working with seminaries, helping them do specific webinars, community projects, and behind the door giving them template boxes that we created so they could carry out their projects. But then when people say what you did, you don't really have that much proof because Drew did it, not Vanbert, or Baylor did it, not Vanbert. So realizing if you want to have some larger grants, you got to make sure your name is a little bit more visible in some of these projects.
Right.
Sure. Yep.
Absolutely.
And to be able to build those contacts outside of Vanbert.
Exactly.
That's interesting. And it's interesting the way that you mention, Brooklyn and Manhattan, and even within Philly. I mean, you could be in the same zip code or the same city, and we see this in Wilmington too. My background is women's health, and so I know that in the state of Delaware, a black woman is 7 times more likely to die during childbirth, but in the city of Wilmington, it's 9 times more likely.
Wow.
And so, and that's just on the other side of I-95, like from one side to the other. And so, we have these resources in the same city, and there are huge groups of people that are not getting them. And so, absolutely, I agree.
Yeah, and I just think about what you said about the Brooklyn versus Manhattan, just right across the river. Like, everything is so different.
I know.
Yeah. Although Brooklyn has changed significantly in the past decade.
Brooklyn has certainly.
Yes.
Yeah. And, here in Delaware, we know that we only have a few hospitals, and we know that access is an issue. You can see it pretty easily. But when you think about a city like New York or Philly, where there are all these hospitals, and we talk about choices, and you could choose the hospital that you go to because there are so many. But that's a luxury. That's not free to everybody.
It doesn't speak to the disparity either, too.
No. Yeah, absolutely. So that's a great point. And so you've done a lot of health equity work here at Bayhealth as well. So what have you done here within our local community?
Oh, I don't think we have really done much concretely yet with the local community. So one of the things Vanbert had to do, it's a board. We had to decide, are we going to shift? We were incorporated in Delaware, but we weren't necessarily located in Delaware.
Sure.
So that was one of the things we decided, that we were going to locate to Delaware and set up base in Delaware. And so we are actually in the process now. Have submitted forms and things, and we've joined the Healthy Living Coalition
Oh, nice.
to do some real intentional work with groups. But the first thing that really happened when I first got here, I had reached out to the hospital, and we just really didn't have the time. I mean, I got here in April, like started April 18th, and we tried to get a grant, and Evan is now retired, Evan Polanski. We tried to quickly get a grant through Pfizer for some health literacy things here. And that was sort of my first exposure to the people here who were doing some things. And that led to me presenting at the Delaware Healthcare Forum one year on the work that Bayhealth did with cardiac readmissions
Sure.
and decreasing them down to zero based on population health data. So after that, the majority of what I've done Bayhealth related has been really focused on that American Health Association, American Hospital Association stuff with the steering committee, but really where are we going to go health equity wise? And my little lever is on the culturally appropriate thing. So my moonshot wish, and it's a public space, hopefully, is that I'm a New Yorker, and I have access to the Health and Hospitals Corporation in New York, who already has a fully up and running, established, multilingual, talking easily 20 languages and multiple more dialects of already curated paperwork on consents,
Yeah.
discharge forms, the advanced directives. So how do we leverage what we said, relationships, to, as opposed to paying a consultant, I don't know, $70,000 to do this? How, can we leverage relationships to just get the templates from HHC and get them up on Bayhealth's webpage? Right now, here in Delaware, we have Creole people, we have Spanish-speaking people, we have multilingual Amish people, and yet still Bayhealth's webpage is pretty much only English.
That's true. Yeah.
That's a good point.
So how do we quickly move on that? To me, that's low-hanging fruit. And so I'm hoping from my little area and being a mid-level person that we can get the green light to, for lack of a better phrase, bypass bureaucracy, get this stuff done, get this wording, let our amazing marketing people clean it up into Bayhealth style and get it on our out there on our webpage and social media places.
That'd be amazing.
That would be.
Yeah. Absolutely. Wow. Are there any other areas that you're working within Bayhealth to improve the equity and access?
I've been working with Dr. DeSimone on the GME-DEI subcommittee.
Oh, yeah. Yep.
And what we have been trying to do there, besides the cultural grand rounds, is we're hoping to see, excuse me, if we can figure out a way to create career mentoring. And we're at this weird point where I think we've all coalesced around it now. We don't want to necessarily just make it minority or underrepresented specific mentoring, but mentoring period. And some of those conversations have been out of the fact that, yes, I have great African American mentors, but I also have significantly great non-African American mentors. It's, at the end of the day, is the person really invested in you and your career?
Yeah, absolutely. And you all have also added on that topic, you all have added the undergraduate medical rotations for those who are in underrepresented groups.
Yes.
Correct?
Yes.
So we have medical students who are spending time here in Bayhealth to be able to have access to that mentoring and to high quality healthcare through their education, and which is just really great. I'd being from GME myself, I get a little I get a little bit of that information at all of our meetings, and so I don't know that that's something that the rest of Bayhealth even knows exists.
Yeah, thank you. Yeah, that's weird to me because, Dr. Slimy's out there and she says it at almost every medical staff meeting, but like, you're like, did anyone hear that?
Yeah.
And we're hoping to really grow it. Right now it's about just a few, but once again, we are less than 2 hours away from 3 major metropolises. So, and as the city of Dover is looking to refashion its downtown area, how do we expand that to where this is almost a second site?
Yeah.
For whether it's Hopkins, Jefferson, PCOM, Howard Med, whichever. Like, all of them can come here.
Yeah.
And to me, I get excited about that from the standpoint, imagine having those medical students from literally 5 different medical schools, 5 different communities spending time together.
It'd be wonderful.
And what that means for them in their career and connections. It's
what it means for us here at home, too.
Yeah.
The impact that we can feel from that.
Yep.
Exactly.
And we also know that patients, hopefully this becomes a generational change, but we know that patients feel more comfortable with people who look and sound like themselves. And whether we fix that or not, I mean, that's human nature. And so being able to expand that for our community would be amazing. I know we've tried to do that in the Sim Center, that we now have mannequins of all different skin tones and genders, because it goes the opposite way. And if we're practicing with patients and you're practicing on a mannequin that is the lightest skin you can possibly find, but you're saying that this person is another another race or gender, or that they have these risk factors that don't make sense, it just doesn't come together the way that you want it to. So
no, and thank you so much for bringing that up, because it's not touchy-feely hearsay. There's data out there on when the trainees get polled.
Yep.
These things matter, and it's so weird. Like, all of us, myself included, like, I think it's just weird how God naturally created us with having blind spots, because we all have blind spots culturally.
Absolutely.
It's like we walk around and think, yeah, I noticed it, but then when someone subtly asks you a question in a survey about it, then you realize, no, I actually was not paying attention to that. I was not as equal or equitable about that as I thought I was, which is just really weird that and Dominic Kayada has a really great way of saying it from the page. It's like, can you be humble enough to not think it's about you when you're engaging the patient?
Right, exactly. It's not your agenda. It is, as you mentioned, caring for patients so that they leave feeling a little less broken. Yes, we have the knowledge of how to care for these patients, but it's still technically their agenda. I mean, and so I mean, you have to be humble enough to care for them.
No, it isn't, and it's real. Like, my drive down here, one of the things, particularly from the surgical mindset, we are gunners, egotistical. We want to win. We want to let people know, hey, not only are we good, we're very good. That's how it's hard to escape a surgical residency with some aspect of that being your personality. But then you also have to really, as you just led to, that the patient might have a really different agenda. And before I left, I get a phone call from a nurse said that I did a procedure, and she's there, and nothing looks like what it should. And I'm thinking myself, this patient called me about a month ago and really kind of leaned into me. I want ATA. And I was like, all right, okay, sure. I'm not actually sure why you're this disgruntled based upon previous behavior. But okay, we can figure out a way to make this happen for you. At the end of the day, it's care we can do. You're clearly voicing that you want it. Yeah. No, there's no confusion anymore. We're going to do what it takes to make it happen.
Yep.
why on earth would you go sabotage it 3 days later? And I don't know, we talked for a while, but I looked at the clock, I was like, I have to be somewhere, but we're going to finish this up next week. But I left driving down. Did they really? What did I miss here? You got what you wanted, and you've already sabotaged it. So that's going to be some more detective work. Like, what? I missed something.
Maybe there's something underlying. That's where we started this conversation. Yep. Well, I hate to say we are close to the end of our time. Is there anything else that you wanted to share with our Bayhealth community and the community at large?
Oh, well, I think in terms of just specific to wound care is really becoming an exciting field, and there's some great innovations coming through. And ironically, one of the greatest innovations I think coming through is the basics of what is being called wound hygiene. And there's just real quickly this aspect of every time you see a wound, actually treating the wound. So cleaning the wound properly, cleaning the wound area, debriding the wound. There's almost any chronic wound has stuff on there that needs to be removed. Refashioning the edges and things of the wound so that they don't curl over and retain things that'll just block your, impede your process, and putting appropriate dressings on. So that nuance of which we have a lot of patients and even other clinicians don't use alcohol, don't use peroxide, don't use betadine. They're actually way dangerous. Yes, we can get it that you might use it if you had a traumatic wound and you were cleaning it the first time the injury happens, but that's not your standard. And that there's some really great things out there, whether it's HibaCleanse based or one of these products we're actually doing a little study on now right now in the Wound Care Center with hypochlorous acid, and then Dakins, which has been around for a while. But that thing of you also want to cleanse the wound with something stronger than just saline. And keeping the wound covered, that basic stuff of stop touching your wound. So that blows my mind. What are you doing? Who told you your hands were clean? No, they're not. They're not.
Yes.
And then the tissue products, and for people who may not know, they understand the tissue products of the grafts, feel free to reach out to us at the Wound Care Center, and don't feel bad because even people who are quote unquote in the wound care business still don't appropriately understand them. At the end of the day, for the most part, they're less than 10 years old. But what these products are doing are really bringing game-changing possibilities. So in the case of your father, you were saying with the bone infection, osteomyelitis, I have a little case series that I did last year on patients with osteomyelitis, long-standing wounds. And I put a specific product on them. And the whole goal was not necessarily about is it going to fully heal, but one of the things that often gets lost is if a person has that infection in the bone, it significantly decreases the success rate of a flap, even if you flap them.
Yep.
So what can we do to put that patient in a potential thing that if they get a flap, they have a higher success rate? And can this product give them that granulating bed as opposed to that messy, tendon, bony configuration you normally see in these patients? Lo and behold, out of the 7 wounds, 6 of them, it did it in 6 to 7 months. And one of these patients got the flap, and this was literally his 5th flap, but this flap so far, and we're about 4 months later, Dr. Sarek did it, this one is taped.
That's awesome. Yeah.
So,
Fantastic.
what does that mean for nursing homes and other patients? Is if this suspicion, because this is suspicion, it's only 7 wounds,
Right.
But what if other people start doing this, and that really starts to be the possibility with these products? What does that mean?
That'd be amazing.
That sounds like it's has great implications.
Yeah.
Definitely.
Yeah. Wonderful. Well, thank you so much for joining us. It was great to sit down with you and chat with you. I've certainly seen you out and about in the hospital, and so it's nice to get to know you. Thank you so much for joining us.
Yes, thank you for joining us today.
Both of you, thank you very much for the invitation, and thank you for how because I know this is not easy, like getting the word out about us here at Bayhealth.
Yep, absolutely.
Thanks for joining us on Scrub In, a podcast on humans, heroes, and healthcare. If you enjoyed this episode, be sure to subscribe and follow us wherever you listen so you don't miss what's next.
Please leave us a review, tell a friend, and come scrubbing with us next time.